And so they were preparing for something big. My name is Tom. I'm a cardiac tele nurse. PPE's always a top concern because is it appropriate? Is it adequate? Is it going to keep you safe enough to where when you go to the next patient's room, they're protected? When you go home, your family protected? And because everything was so new, we were learning as we went along. So there wasn't a really established things. It was an airborne precaution. It was a droplet precaution. You know, the whole medical community was trying to figure this out as in real time as it's happening. And sometimes that creates anxieties and fears and stresses, and you're not sure if you trust your equipment or if you're even using the right equipment. And then if this is available, you will use what's best possible based on availability. And you're seeing other facilities in other parts of the country in situations that we may not be in, but we have to prepare for that. So now we're rationing, we're trying to get as much life out of everything equipment-wise as possible to ensure that it's there tomorrow. Even just walking in the halls, it's booties, caps, surgical mask, and social distancing just in the common areas. And then as far as entering a patient's room goes, we're going in and we're gowning, gloves, either N95s. Some nurses have brought their own protection as far as masks and respirators that exceed N95s. We use PAPRs as well, which use positive air to keep airflow in front of the face to keep that down. A whole lot of new equipment, a lot of different stuff to protect us that was rolled out, a lot of training and stuff like that. But basically it's any point of entry, your nose, your mouth, your eyes, gloves, gowns, everything to go in to go to bedside. It's a little stressful because you got to do it right to not contaminate yourself or others to get there fast enough to do what you need to do. Haven't got caught up that much in the moment because if we're not safe, we can't take care of others. I have seen it happen. It's not an uncommon thing. But you try to do the best you can with Zoom, with other resources, phone, from the doorway, keep distance, at least put eyes on the patient first thing, even if it's just a surgical mask, something, hey, what's going on, just to get a quick assessment to see how rapid you need to respond. The whole dynamics have changed, and trying to find best practice throughout this it's evolving. We have to keep all the doors closed on our unit because the entire floor is negative pressure, which is a great advantage. But that puts a barrier between us and the patients. So we do have heart monitors, we have O2 monitors on them continuously, but you can't always assess the equipment. You have to see the person. And so with that, you still need to be able to respond appropriately, quickly, get into the rooms, and not just depend solely on that. So we had to find a way to balance that to where we're not overexposing the staff for unnecessary trips and cluster care, but not neglect or ignore our patients. They still need us, they're still in need. We do a lot of extra roles. On top of all isolation patients, on top of the stress of learning on the fly, we take on EVS roles. We've been cleaning the rooms, wiping everything down. We've picked up, RT has always been there with us and helping us, but if there's a task that's within our scope we can do to keep limited exposure, we've been doing that. Same for our CNAs. We go in there, we empty trash, we empty linens, we do a lot of total patient care as nurses to limit exposure for other staff. Yeah, we had a patient that was here for almost a month, and we really try to keep the patients off the ventilators because it's not where we want to be. It's kind of a last ditch. They don't usually come off very well. It's we want to cut everything off before we get to that point. And so what we've found is by proning the patients, by putting them on their stomach and keeping them oxygenated, they saturate better. Their numbers go up. I've seen it as much as almost 15% just by rolling somebody onto their stomach, to where we can actually start reducing the amount of oxygen consumption they require. And we had a patient who didn't want to go on a vent, who was fighting really hard, and she stayed on her stomach almost 20 hours a day for almost 2 weeks and stayed off the vent. And she was able to go home at the end. And it was a really big deal for everybody, because I think everybody at one point or another came in contact, took care of, assisted, did something to help that patient. And from her being willing to do the interventions, because a lot of people don't like that. They don't like to lay on their stomach. It's not comfortable. They're already having trouble breathing. And it just may not feel natural, but it's effective. And we're seeing that is keeping our patients and giving them time to heal themselves, and we're able to get their oxygen consumption down, and they're going home. My wife's a nurse also, so we have a very nursey household. So nursing is stressful, and so when you deal with what you're dealing with at work and you're processing stuff like that, you go home and it's your reprieve. You regroup, you put yourself back together, you process, you sort the things that the everyday person may not have to deal with, pick yourself up, go back to work, do it again. This is different because this isn't a work thing, this is a global thing. So when you go home, the dynamics are different. For the kids, for the wife, family, everybody has somebody who has a comorbidity, who's at risk. Nobody's really removed from this. So you don't get that reprieve to decompress, because you're dealing with it at work, you're dealing with it at home. You go to the grocery stores, you're standing in line, somebody's always telling you where to be, what to do. Maybe this is best, maybe that is best, and a lot of uncertainty. And so the burden of it is heavier than it would be if this was just something that existed in the medical world. We've done really well as a unit and personal. All my family has been healthy. Everybody in our unit, after dealing with this for 8 weeks, we still don't have anybody who's contaminated themselves or cross-contaminated, so we're doing something right. We are protecting ourselves and each other, and not taking it home or out to the community. So that's been a really big accomplishment. It's good to be a part of something that matters and do something that makes a difference. But the concern always comes back to what do we not know? What am I going to bring home to my kids? Yes, I like helping people. Yes, I like doing what I do, but not at the expense of my kids, my family. That I do this to provide for them and care for them, just like, and I take care of the people I'm responsible for in the same manner, but my responsibility is to my family. So am I putting myself in a position that puts them at risk? We had people living in campers in their driveway, avoiding their family, not being around them. We have other people, other nurses, excuse me, we have other nurses whose family only see them by video because of where they work. A lot of people disappear when they find out that you're a nurse, and then they find out you're a COVID nurse, and it's crickets. They're gone. using the proper PPE, washing our hands, being diligent. After 2 months of COVID patients all day, every shift, picking up extra shifts, doing all the stuff we need to do to make this happen, and people not not that it shouldn't be taken seriously like anything else, but it appears to be on par with everything else we've dealt with in the past. When it's new, we're figuring out, we're learning, but it's manageable. We'll be able to get a handle on this like we have everything else, from HIV to C. diff to all the other stuff that we deal with throughout the community, and we're able to take care of these patients effectively without hurting ourselves or others, or cross-contaminating, all our areas of work. So I just think it's still a work in progress, but we are making progress. Because we're still early on, there's not a silver lining yet, but we're starting to see things emerge. We're starting to see more access to doctors, because now we've been forced to use telenursing. We're doing stuff, through Zoom and Skypes and through video, which gives people more access. It's more efficient. We're starting to see people's skill sets are getting more exposed. They're dealing with more critical patients. People are being pushed out of their everyday routine and having to step up and be better nurses and RTs and doctors, because that's what's being required of them. So it is a push forward. It is progress. It is something that will progress the medical field. As time's gone on, the anxiety, the tension of caring for these patients has decreased, because with familiarity, with equipment, with cleaning, with everything that's required to take care of these patients, as we become more familiar, we become more confident, and so the care gets better. The standard of practice starts to be established.